Good day, my name is Imelda Williams. This presentation will focus on abnormal radiographic appearances of the cervical spine. When you view cervical spine images, it's important that you are able to identify the normal radiographic appearances so that you can discriminate between what is normal and what is abnormal. I hope that at the end of this presentation, you will be able to apply a logical method to accurately interpret abnormal radiographic images of the cervical spine. And it's important that you are able to identify the normal radiographic appearances so that you can then distinguish any abnormality on the different C-spine projections. Crucially, you should be able to distinguish whether a C-spine injury is stable or unstable, and then apply a systematic approach so that you can generate informed opinions when assessing abnormal C-spine radiographs. I've given you a number of textbooks, and these are all electronic, so on the Moodle site you will have access to all the electronic resources. The image interpretation manual, the pages for the spine is from 202 to 209. And then in Otto Chan, the chapter there is chapter 10 on the cervical spine, and in Rabies, Accident and Emergency Radiology, the chapter is chapter 11. Just a reminder about the mechanisms of injury. So the types of mechanisms would include hyperflexion, hyperextension, rotation, axial compression, distraction, and shearing forces caused by lateral bending, and complex mechanisms of injury, which would be a combination of different forces. So when you look at the C-spine, the key consideration, is it abnormal? And if it's abnormal, is there a fracture, or is there a dislocation, or is there a fracture and a dislocation? So you want to determine whether the injury is stable or unstable. As you well know, spinal compression requires urgent surgical decompression. So most benign tumors, the extramedullary tumors, would be removed surgically and should have a good prognosis. A paraplegic can recover if compression is relieved before permanent damage has occurred. Metastatic tumors overall has a very poor prognosis. Classifying spinal injuries according to the movement. So with flexion mechanism of injury, you should suspect an anterior wedge fracture of the vertebral body. With an extension injury, this could result in a possible small avulsion at the anterior superior or inferior vertebral body corner. Compression injuries typically result in a burst vertebral body fracture fragment, which is then propelled posteriorly into the spinal canal. And distraction injuries, as anterior vertebral body height remains intact. However, the posterior horizontal fracture of the posterior body or neural arch can occur. With translation mechanism of injury, you should suspect subluxation or an obvious dislocation. Now, looking at fractures of the occipital condyle, they are rare and is a result of either rotation, lateral bending, or combination. Mechanism of injury. These are very difficult to pick up on plain X-rays, so you need a very high level of suspicion, as plain X-rays are not very sensitive. CT is recommended if there is a high suspicion, and then also to have coronal reconstruction. Now, Anderson and Montesano has a classification for occipital condyle injuries. Type 1 is comminution of the occipital condyle. There is minimal or no displacement of the fragments into the foramen magnum, as the alar ligament keeps it intact. Type 2 is a fracture as a result of the basilar skull fracture, and the alar ligament still keeps it intact. Type 3 is an avulsion of the occipital condyle fracture, and it is moves towards the tip of the dents. The contralateral alar ligament and the tectorial membrane is loaded, and therefore this can be potentially unstable. Occipitocervical dislocations due to trauma is usually fatal. However, with quick response and management of patients, we do find that some of these patients do survive. The dislocation is classified according to the direction of the displacement of the occiput. If it's anterior displaced, this we can see on the first image on the left. It can be vertical displaced, as you can see on the image on the right, or it can also be posteriorly displaced. Jefferson's fracture is a fracture of the ring of C1, and as you are aware, when there is a ring-like structure, you should suspect more than one pathology, and therefore it involves both the anterior and the posterior arcs. What you should look for on the open mouth view is lateral displacement of the lateral masses. If it is greater than 7 millimeter, then you should suspect an unstable fracture. Also look for asymmetry in the space between the odontoid and C1 as shown in the arrow, and then the lateral masses of C1 will overhang the lateral masses of C2, as you can see on the right side of the image. The odontoid is attached to the occiput by two ligaments. Mechanisms of injury that can result in odontoid peg fractures are hyperextension or hyperflexion. And there's three types of classification. Type 1 is quite rare. This is an oblique avulsion of the tip of the dents. Type 2 is the most common. It occurs through the base of the odontoid. The blood supply is often compromised, and therefore it is mostly unstable, and there's also a risk of non-union. Type 3 extends into the C2 vertebral body and can be stable or unstable. So Anderson and D'Alonzo's classification then, as discussed, type 1, we have the upper dents. Type 2, which is the most common, is at the base of the dents, and then type 3 is at the body of the axis. And according to Anderson and D'Alonzo, type 3 would have a much lower risk of being unstable than your type 2. So if we look at this image, we are able to see that there is a loosened line that goes into the body of C2. So this is a type 3 odontoid fracture. Hangman's fractures are bilateral fractures of the pedicles of C2. So if we look at this image apologies, behind the vertebral body of C2, we can see the fractures of the pedicles. Also, if we apply our lines, we can see that there is anterior dislocation of the vertebral body of C2 onto C3, and also that look out for signs of prevertebral soft tissue swelling. So if you suspect a Hangman fracture, look for a fracture posterior to the spine of C2, and then displacement also of the posterior spinal line as well as the anterior spinal line. Hangman's fractures can be classified, so this is a simple classification with type 1 is a fracture through the pedicle. Type 2 is a fracture through the pedicle as well as disruption of C2, C3 intervertebral disc space. And then type 3 involves fracture through the pedicle, disruption of C2, C3, as well as an associated C2, C3 facet dislocation, as we can see on the diagram. Burst fractures occur due to axial compression. It's associated with soft tissue swelling and neurological damage. And if you look at the vertebral body, normally this is comminuted. There's reduced anterior vertebral body height, so you have anterior wedging. And if you look at the alignment, the posterior vertebral line will be pushed backwards, so it means there's fracture fragments into the spinal canal. Importantly, you can also look at the spinous line. So you have on this image, so if you look at, we've got 1, 2, 3, 4, 5, 6, and 7. So between 6 and 7, we can see that the spinous processes are much wider. This is called fanning of the spinous process, and that is due to the anterior compression. Hyperflexion teardrop fractures are the most severe type of flexion fractures, although they might look quite simple. What you need to look for in the vertebral body is a triangular anterior fracture of the inferior vertebral body. Sometimes it can be superior. It's associated with posterior displacement of the vertebral body into the spinal canal, and there is a high risk of neurological damage with hyperflexion teardrop fractures. Cervical facet injury. Facet joints provide stability and also guides motion, and it is essential for ligament injury. So cervical facet injuries are caused by acceleration, deceleration injuries such as a whiplash type injury. If only the one facet joint has been injured, if it's unilateral, then it's stable. However, if it's bilateral, then it is unstable. So in this image, we can see the cervical facet ligamentous tear, and you can also see that there are two cervical facet ligaments. So if one ligament has been torn and the other one is still normal, it still holds the cervical body in place, or just with the subluxation. So when we look at unilateral facet dislocation, this is seen as anterior movement of the affected vertebra up to about 25% of the width of the vertebra below. So if again we look, so at C5, C6, we can see that C5 is forward anteriorly displaced. Importantly, there is a bow tie sign on the lateral radiograph, and this we can see between 5 and 6, and this is shows the presence of a unilateral facet dislocation. It is created by the misaligned pedicles of the dislocated vertebra. Bilateral facet dislocation is due to extreme flexion of the head and neck. The vertebral body is displaced anteriorly 50% or greater, and there is a high incidence of spinal cord damage. And on this image, we can see C6, C7, and there's definitely more than 50%, so this is a bilateral facet dislocation. Bilateral perch facets. This is due to vertebral subluxation as a result of a flexion injury. These are best demonstrated either on the lateral of the cervical spine or an oblique of the cervical spine. CT is really important, and with sagittal as well as oblique reformation. So on image A, we can see that there is obliteration of the C6, C7 facet joint. You can see that with the black arrows, and the spinous processes are displaced. On the lateral view, at C6, 7, and again where the arrow is, you can see the perch facets of C6 and C7. Clay shoveller's fracture is an avulsion fracture of the spinous processes, commonly of C6 or C7 spinous process. This is caused by severe muscle contraction. It's a stable fracture as it does not affect the posterior vertebral line or the spinolaminar line. Sometimes you might be able to see gas in the prevertebral space, and this is normally best demonstrated on a lateral of the cervical spine, and it most likely will represent either a ruptured esophagus or trachea. Just to be aware of some congenital abnormalities. So on this image we have hypoplasia of the dent, so you are not able to see a true odontoid process. And then on this image of the lateral spine, there's an incomplete arc of C1. And just a little bit about some of the common pathology. So with rheumatoid arthritis, it's important that a lateral view is obtained in flexion, and the radiographic appearances you need to look for is erosion of the odontoid process. And if you look on this image, there is subluxation of C1 on C2, and there's also disc space narrowing, and then also sclerosis of the vertebral body margins. Remember, you identify C2 because of the Harris rings. Degenerative changes to facet joints are quite common in the mid to the lower cervical spine. Osteophytes can form in the posterior aspects of the vertebral body, and they may encroach on the neural foramina and then can cause some spinal damage. So what you need to look for on C-spine is signs of disc space narrowing, and then also for spondylolisthesis, which means forward movement of the cervical vertebra. Radiographic features of ankylosing spondylitis includes osteopenia, squaring of the vertebral bodies, and then syndesmophytes. These are ossifications of the annulus fibrosus, and which results in a bamboo-like spine. And then also ossification of the ligaments. You can see it especially on the anterior ligaments. And then ankylosis, which means fusion of the spine. The take-home message of this presentation is that when you view images of the cervical spine, you need to consider the mechanism of injury, because that can inform what type of pathology you can expect on the cervical spine images. You also need to apply the ABC systematic assessment of the cervical spine so that you do not miss out on any pathology, and you must be able to identify typical traumatic radiographic appearances as well as common pathologies of the spine. Thank you.